Okay. Hi, good afternoon, Prof. Philip. How are you doing?
Good, I'm good. How are you? How are you, Dr.
Very good.
Prem?
Very good. Thank you for joining us. And I know it's difficult now because everybody is working from home,
Yeah, yeah, it's a new normal. That's right. Yeah,
and trying to adapt work and home activities. It's becoming a bit of a new norm, I think. Huh?
yeah, yep. Well, it's been about what 2.5 months, so I
Right.
think some of it is, getting assimilated and getting used to already.
Right. Right. We are getting used to the new way of living. Yeah.
Yeah, yeah,
Change is always difficult.
yeah. Normally, change takes at least 21 days before you can adapt. So,
Really.
we've gone beyond 21 days. Of course, some people may be more vulnerable to, you know, to have more longer periods to try and cope and adjust.
Mm,
But generally, it's a common theme. You need
mm.
21 days for change to become, adaptive for anyone generally.
About 3 weeks.
Yeah, yeah.
Okay. Um, okay. Thank you for agreeing to do this, Philip. I know you have a tight schedule and it's very
Mm,
difficult to catch you. So thank you very much for agreeing.
yeah.
Um,
Well, I'm not going anywhere right now, so it's fine. Yeah.
okay. So our topic for today, I think, is definitely your area of expertise, and I know that
Mm,
you do a lot of work with. Well, you're the addiction specialist, and you see
mm,
quite a few of our patients as well. And
mm,
one of the key reasons that we keep bringing patients back to you very often is this thing that about dual diagnosis or comorbid disorders.
mm.
So I thought that you would be the right person to speak to, to share some of experiences with the public on why is it that why is it that it's so difficult when it comes to addictions, and like the symptoms.
Mm,
Some of the symptoms of addictions are so similar to mental health illnesses, and it often confuses us when we are treating. So uh,
yeah,
the chicken or the egg, which came first, right?
yeah, true. Yeah, well, sometimes it's really hard to identify which comes first. But the important thing is to assess and do a complete assessment to identify what the conditions that are underlying the substance use problem are.
Mm,
So they can be a variety of things.
mm,
Uh, the statistics actually suggest about 40 to 60
mm,
percent of people with a substance use disorder have a mental health problem.
mm.
Now that's a huge figure. It
It is.
means about half or more than half of people with a substance use problem have a mental health issue,
Mm,
which, if not addressed, is
mm,
actually going to contribute to perhaps relapse of their
mm,
substance use problem. It's also
mm,
going to contribute to poor outcomes. When you
mm,
treat the substance use problem, but you don't treat the underlying mental health issue, then you're going to have poor outcomes. You're also going to
mm,
have poor, sort of, uh, you know, uh, physical health related
mm,
to the condition. The combination of the mental health problem and the substance use can actually lead to poorer physical health issues as well. And it
mm.
also increases suicide.
Of course.
Uh, and so, yeah, so I think it's important for us to understand that the two are very commonly associated, and
Mm.
it's essential that we do a complete assessment in people with presenting either with a substance use disorder or even with a mental health issue. You
Mm. Actually, 40 to 60% is such a huge figure, yeah, when we think about it.
know?
Because
Yeah,
now we're only talking about mental health illnesses. Now, what about
yeah,
all the other conditions that come with substance misuse? Like, for example, trauma, or what do you call depression at home, or not depression, upbringing issues,
yeah,
psychosocial environments,
yeah,
how it influences the substance use. There are
yeah.
so many things that influence or
Mm.
predispose some people to becoming at risk, right? But
Yeah,
just
yeah,
with just with mental health, you're talking about 40 to 60%. That's huge.
yeah. So, I mean, the terminology, the old term was dual diagnosis,
Correct.
suggesting that there is a mental health issue, either an
Mm,
axis 1 or axis 2 mental health
mm,
issue,
mm,
and co-occurring substance use disorder.
mm.
Dual diagnosis has now been changed to co-occurring
Comorbid. Yeah.
disorders. Yeah,
Co-occurring, yeah.
co-occurring.
Right.
Yeah, because the important thing is to address both of them. They're
Mm.
co-occurring, and too often we're looking at the chicken and egg, and
Mm.
that's not really very important.
Mm.
We don't need to really identify which started first, which
I
came
agree.
later. The important thing is that they are both co-occurring, and we need to address both of them. We
I
cannot,
agree.
do justice by just managing only one of those conditions.
Mm. Some of the things that we see in treatment, for example, right now, when
Yeah.
the patient is using substances, you may not see so much of the psychotic or mental health illness symptoms, right? You may not observe those symptoms
Mm,
when he's,
mm,
because the drugs may be what you call anesthetizing or numbing or masking the actual
masking.
symptoms,
Yeah.
right?
Yeah.
But when they come into treatment, the first couple of days, they seem okay.
Mm,
Now, after
yeah.
a week, after 2 weeks, when there's no more drugs to mask the symptom, suddenly you see
Mm,
patients becoming psychotic.
yeah. Yeah. Yeah.
How? I remember you and I had a chat about this some time back.
Yeah.
Shanmugam, I was asking you,
Yeah.
can we
Yeah.
pre-treat the
Uh,
psychotic symptoms? You know,
yeah.
can we
Yeah.
medicate them before they actually become psychotic? Is that a possibility?
No, not really. Actually, the thing is, first of all, we need to have a period of abstinence before we can actually uncover what the underlying mental health issues are. Many substances have an impact on the brain depending on the type of substance that's used. So if it's a stimulant, they can create maybe hyperactivity or psychosis or symptoms similar to mania or schizophrenia.
Mm. Mm.
If it's a depressant, it can create anxiety, especially during withdrawals or depression. And so it can be due to the drug itself, the specific drug.
Mm.
If it's a hallucinogen, then of course it can create symptoms similar to psychosis,
Yeah.
schizophrenia like symptoms.
Mm.
Now you won't know if that's due to the drug or an underlying illness until they've had a period of complete abstinence.
Absolutely. Mm.
And that is the tricky thing. We need to at least ensure there's abstinence for about a month to a
Mm.
month and a half before confirming a diagnosis of a co-occurring disorder or a dual diagnosis. You
Mm.
so in that interim, of course, sometimes we can use medication and treatment as symptomatic relief.
Right.
So if people show psychotic symptoms or if they're very depressed, then we can use medications temporarily until we have a full assessment done. But sometimes we use psychological therapy. So if people are not having too extreme symptoms, then cognitive behavior therapy may be helpful.
Mm.
Other therapies can actually tide them through until we have that complete abstinence period to be able to confirm the dual diagnosis.
Mm. So it actually takes about a month to two of abstinence
Yeah, a month
before
to a month and a half, sometimes up to 2 months. You're right. Yeah.
before we can actually start to medicate the symptoms. Correct?
Well, if
Or,
the symptoms are initially, if the symptoms are serious and they're causing a lot of, sort of distress, then we can symptomatically treat them.
symptomatic
But
treatment. Okay.
yeah, so just managing them temporarily. For example, somebody who is using for amphetamines,
Mm.
typically during withdrawals, they can have psychosis. They
Mm.
can also go into deep depression. The risk of suicide can be high. So
Mm.
during that period, you may want to medicate them as well temporarily, and then observe later. Trying to take them off the medication if those symptoms persist. And if they
Mm.
do after a month or month and a half, then you need to assess for their underlying co-occurring disorder.
Mm. Okay. Often when we see parents or families who bring in their loved ones for treatment, and there
Yeah.
is a co-occurring disorder, one of the questions that we often hear from family members is that, uh, how will we know which came first? Did my loved one
Mm,
become addicted because of the mental health, or did
mm,
the addiction cause the mental health? And does he have to take medication for the rest of his life?
mm,
How long after can he stop the medication? These are some of the common questions that we hear. And is there like I don't know, I don't think there is an exact answer or a definite time frame, right? Is there?
Yeah. No, it actually depends on various different factors. I mean,
Yeah.
if it's early into the illness, then very often the treatment is, for a certain time frame only,
Mm.
and after which we can actually start to reduce, taper, and monitor symptoms and come off medication. But this has to be done together with the treating doctor, and it's important to seek consult before deciding on that. But in some people whose illnesses or their substance use has been for a long period of time and they've had several different relapses, then longer periods of maintenance treatment. It's
Right.
no more, helping them to get better, but it's actually maintaining them,
Right.
sort of preventing a future relapse. That's going to be essential. And that may be for years.
Yeah.
You know,
Yeah.
I don't think there's anything that's lifelong. There's there's no illness that states that it has to be lifelong, but it depends on when you actually seek treatment, when you get into treatment, and how many episodes you've had. And
Mm.
most often, people can come off their medication.
Mm. I suppose, yeah, you said something right. I mean, you
Yeah.
said something interesting. You're saying everything right. I'm sorry, but you just said something interesting. No, I suppose it matters at which stage of their addiction that they come into treatment,
Yeah,
right?
yeah,
At which stage of
yeah,
the severity that they come in, and that helps us from a
that's right.
treatment perspective. This
Yeah,
morning I was seeing a family, and we were talking about dual diagnosis, and sometimes families are not happy with medication, right?
mm,
Because there is this conception that I can get addicted to the medicine, and then I'm stopping my
mm,
substance, but I'm being addicted to the medicine. We hear this very often. Um,
yeah,
it's difficult to explain sometimes that you need the medication to treat the other mental health illness. Then only we can work with the substance dependence.
yeah.
There's always this thinking that medications will make things worse. How do you manage that, Philip, when you see the family? What do you tell them?
Yeah, well, we have we have different groups of medication that we use in psychiatry.
Okay.
And especially in co occurring disorders, we have to be a bit careful about the type of medications that we use. So there are the anxiolytics or
Mm,
sedatives,
mm.
which typically are addictive. And
Okay.
so those are medications that we would try to avoid,
Avoid, yeah.
especially in those with a history of substance use disorder,
Mm,
because you can substitute one addiction with another, and
mm.
so we don't want that to happen.
Sure.
But when they have, for example, symptoms of depression
Mm,
or anxiety, then there are medications that can be used. For example, the SSRIs or the
right.
SNRIs,
Right.
the selective serotonin reuptake inhibitors, so the serotonin norepinephrine reuptake inhibitor, and these are not addictive,
Mm, mm,
uh, but they're in the same class like antihypertensives or
mm.
diabetic medication.
Right. Right.
You take insulin, you don't get addicted to insulin.
Right. Right.
But when you stop taking it after a while, you get into a bad ketoacidosis
Right.
sort of episode, or your blood pressure goes off the roof and you're risking yourself for stroke.
Yeah.
So the thing is, very commonly, if mental health disorders are not treated early, they
Mm,
become similar to hypertension and diabetes, a
mm,
chronic relapsing illness.
mm,
You
mm,
may need to be on medication for a period of time to
mm,
to ensure that those relapses are not going to happen. You're going to be stable and you're going to be well. And that's
mm.
why I tell a lot of my patients, the earlier you come in for treatment, the better your outcomes are.
Of course.
You most probably going to be off medication in a short period of time. There won't be a need for maintenance and
Mm,
long-term treatment, and you'll be medication free. But once it's become a relapsing illness, it's
mm,
really hard to say that you can come off medication early. You'll have
mm,
to be on it for a considerable period of time.
mm. No, as a therapist, a psychologist, from a treatment
Mhm.
perspective, I must share
Yeah,
my struggles. Initially,
yeah,
when we started treating people, now we use
mm,
the abstinence model of treatment,
right,
and the abstinence model of treatment basically says, of course, you stop all your addictions, and there's no such
yeah,
thing as moderate drinking. That's the abstinence model.
mm, Mm.
So from a treatment perspective, even for me personally, initially many years ago, it was
Mm.
difficult to understand the concept that medication is a necessity, because
Yeah.
abstinence means you have to stop everything, and now I'm
Yeah.
substituting it with medication. It took me a while to understand that without the medication, it's going to be
Mm.
very difficult to treat other things.
Yeah.
Uh, it took
I
me a
mean, I
while.
don't think you can tell someone who's going through an abstinence model or treatment that, well, this means you got to stop your antihypertensives, or you got
Yeah,
to stop your aspirin for your heart disease,
correct, correct.
or you're not going to tell them that. So
Yeah,
similarly, you tell them stop this medication for a disease that's actually affecting the neurochemicals in your brain, and it's a chronic relapsing disease.
which
You
it
know,
is.
so yeah, so actually, if we put that all into perspective, I think we understand it better.
Mm,
It's not an addictive drug.
mm,
It is actually treating to stabilize neurochemicals.
mm,
And as long as we use the appropriate medication, people are safe. They're not going to get dependent and develop tolerance and withdrawals from medication that are used for helping their mental health problem.
mm. I think another difficulty with patients on medication is compliance. And you mentioned it earlier, you need to discuss it with your doctor before you cut your medication
Mm,
or you change it. It's very important to consult the doctor, because sometimes people just, I mean, generally people don't want to be dependent, or they don't like
yeah,
the feel or the taste, and then they just stop it. But what I think the
yeah.
patient need to know is that if it's not working for you, discuss it with the doctor, and
Mm,
and they can move things around, or they can review the medications and adjust them for you, right?
absolutely. Yeah.
Yeah.
So
Hello. Oh, hi. I think we just Philip got dropped.
sorry, I think we got lost
Oh,
there for a
yeah.
short while.
Okay. We lost you for a
Are
few
you
seconds.
there, Prem?
Yeah, I'm here. Are you right? Are you
Hello?
back? I'm here, Philip. Are you I Can you hear me?
Yeah, I can hear you. Yeah, sorry.
Okay. Few seconds.
Internet's not so stable today. Okay. Yeah, so as I was saying, we can divide the psychiatric medications that we use into the older and the newer ones. And the older psychiatric medication, antipsychotics and antidepressants and mood stabilizers, had a lot of side effects. The newer ones are much cleaner and
Mm,
they're easier to tolerate.
mm,
So we can actually adjust things when patients are feeling some side effects. Very often, side effects are temporary; they're only in the first few days of starting
yes,
treatment,
yes.
and then they wear off.
Mm,
So typically in my practice, I would see someone maybe more frequently the first few weeks to
okay.
get them to understand the medication and reassure them, and as well to ensure compliance. And then the medication take about 4 to 6 weeks to work, by which they should already, sort of not encounter any more side effects and
Mm.
be able to see the full clinical benefits of the medication as well.
And this normally works better along with therapy, and medications generally work better along with therapy. Am I right?
Absolutely.
Yeah.
There's no purpose in giving medication without actually combining it with, the
Correct.
integrative measures that you
Yeah.
use even for, addiction. It
Mm.
has to be biopsychosocial.
Yeah.
So medication is the biological treatment. The
Right.
psychological part is therapy, and then the social part where peer support
Right.
and peer group meetings or group therapy, all of that play an important role even with mental health issues and for addictions.
Right. Actually, when you say the social aspects or the biopsychosocial model, I'm
Yeah.
thinking about the social aspect where family is also a big factor in the
Oh,
whole
yeah.
treatment, right?
Yeah.
The family
Yeah.
actually play a big role in
Yeah.
treatment, or sometimes the family actually becomes a huge trigger or a huge reason
Mm.
for some people to turn to substances. And we
Yeah.
see the
Yeah.
childhood trauma, upbringing,
Yeah. Yeah.
um, the environment. If I'm growing up with a lot of anger and a lot of
Mm.
physical abuse and violence at home, that's going to become a norm for me.
Yeah.
If
So that's
I'm
one of the other reasons why it's so common to see co-occurring disorders. The same
Yeah.
triggers for substance use are the same
Mm.
triggers for mental illness.
Yes.
So trauma as a child, bullying, and
Mm.
maybe punitive ways of parenting, and all those experiences can trigger off depression or anxiety. It can trigger off also a substance use disorder.
Yep. And
So, that's why they can co-occur very often. Sometimes people may be developing or may experience some of the early signs of anxiety or depression and then look towards substances as a way of self-medicating.
sure, sure.
So yeah, but again, your vulnerability factors are the same for both conditions. So
Right.
that's why trying to identify which started first may not actually be as beneficial as identifying that this is two different conditions co-occurring in this individual, and they both need attention.
Both need treatment at the same time in order to arrest the
Yeah,
problem, right?
exactly. Yeah,
Um, we do a lot of work with families, family therapy, family
yeah,
work, family
yeah,
psychology.
yeah.
You and I have done some work together with families as well. And
Yes, yes.
sometimes I like to use the term the family can be the dual diagnosis or the co-occurring disorder.
Yeah,
I,
yeah,
the family is the co-occurring disorder or the
yeah,
upbringing for whatever reason. It may
yeah.
have pushed or triggered or traumatized someone
Mm,
to move into substance misuse or
yeah,
substance. And getting family members involved in treatment sometimes is quite a task, um,
yeah.
right? I don't have a
Well,
problem. He has a problem.
yeah. No, you're right. I mean, everyone plays a role in the etiology, in the beginning of the disorder, both substance use as well as mental health disorders. And that's why, even in my practice, if I'm seeing a pure mental illness patient or person with a mental health problem, I would still involve the family.
Right,
They
right,
have a huge role.
right.
They may have some contributing factors towards maybe the onset of the illness, but the important thing is that they can make changes, amendments, and then help in the recovery.
Correct.
And
I
so,
agree.
the whole environment, the social environment, also has a role or a part to play in
Mm.
recovery as well.
In fact, we often say that treating the patient and then
Yeah.
sending him back to an untreated environment is not going to be helpful.
Mm.
The
Yeah,
environment at home needs to be treated as well for recovery to happen for everybody. Recovery has to take
absolutely.
place for everybody. This is a
Yes.
disease, it's a family illness, isn't it? It affects everyone.
Yeah, yeah, I agree. Yeah. So, yeah, the only thing is, of course, when it becomes a chronic relapsing disorder, then sometimes it can be really hard to get families into
Yeah,
the fray to think about actually being involved,
yeah,
because they've been traumatized and they've had, maybe memories that just haunt them, and so then sometimes the journey is just alone, and maybe that's where the peer supports and everything else, finding new family structures for the client that's actually trying to recover is important as well.
mm. Yeah. The structures are very important.
Yeah,
I know we are digressing a little bit from the co-occurring disorder, but
yeah,
it's an interesting topic. Uh,
yeah.
go, Going back to the medications that you mentioned earlier,
Mhm.
Philip,
Yes.
I just wanted to ask a question on what are your thoughts on depot? Now we have Sustaina, Mentena,
Mm.
and all these various things, right?
Yeah,
And
yeah.
you mentioned there are a lot of new drugs in the market now which have lesser side
Mm.
effects and are working really well. Can you share your
Yeah.
thoughts on this so the people who are
Yeah.
watching?
So, I mean, the medications used in psychiatry are in different formulations.
Mm.
So there are oral tablets, there are capsules, there's
Yep.
liquid formulations, there's also injectables, and the long-acting injectables or the depots.
Mm.
Uh, Now, depending on the type of medication, because one of the important things that we often observe, especially in co-occurring disorders or dual diagnosis, is
Mm.
poor treatment adherence, poor compliance.
Compliance. Okay.
And when poor compliance occurs, then we can predict relapses, frequent relapses.
Okay.
So that's where the long-acting injectables are helpful,
Okay.
especially in those with psychotic illnesses or bipolar type illness.
Okay.
Then considering a long acting injectable may be an important thing to discuss.
Okay.
Uh, the older antipsychotics or depots had numerous side effects, but the newer ones that you just mentioned a few earlier actually have very little in terms of side effects. And in fact, may be much preferred to daily oral medication because they have a stable blood level through that whole period. I mean, we've got a new long-acting injectable that's going to be launched soon, which
Oh.
lasts for 3 months. So
Mm.
you come in and get your injection once every 3 months, and throughout that period of time, you have a stable blood level of a medication that prevents a relapse of your illness. So compliance becomes better. You don't have to worry about side effects as much
Mm.
anymore.
Mm.
Again, the maybe the initial phase when you first start taking it, there'll be a few side effects, but then they wear off because these are the newer medications. And
Mm.
in the long run, you stay more stable and you have less risk of relapse. But
Mm.
this is for conditions that typically are more serious. We
Okay.
divide psychiatric conditions into the major mental illnesses and then the
Okay.
minor mental illnesses. The
Okay.
major mental illnesses can include bipolar,
Right.
schizophrenia,
Right.
psychosis. So the antipsychotics are helpful for these disorders. The more common conditions are actually the minor mental disorders, and that's depression and anxiety.
Right. Right.
So anxiety disorder is actually the most common mental
It
disorder
is. Yeah. Yeah.
in the world.
Yeah.
About maybe 15 to 20% of the population have an anxiety disorder. Now you
Mm.
add a substance use into that fray, you get about 40%.
Mm.
You know,
Mm.
so yeah, 40% of people with a substance use disorder are going to have co-occurring
Mm.
anxiety problem.
Anxiety disorders.
Now,
Mm.
yeah, so the treatment of choice there is very often the SSRIs or the
Mm.
SNRIs,
Mm.
and they don't have the injectables or the long-term
Mm.
depot formulations.
Mm.
They are
Mm.
daily oral treatment.
Mm. Mm. Sorry, as we were talking, I was looking at
Yeah,
my message that came in, and
yeah,
this a parent sent me a message
mm,
saying talking about injectables, and
yeah,
apparently the son was in treatment and he was
mm,
diagnosed with the co-occurring disorder, schizophrenic,
mm,
and he refused medication. I was just having a look at my message,
yeah,
and apparently on the injectables is very stable.
yeah,
He's stable
yeah,
and he's compliant. That's the key thing.
yeah,
The family is very happy that he's compliant and he goes regularly
yeah,
because now he
yeah.
realizes it helps him.
Yeah, that's good. Well,
Mm.
actually, this is what we are now trying to change in the mindset of even treating clinicians. That
Right.
perhaps our first line doesn't necessarily have to be oral daily
Right.
medications anymore,
That
especially
was
in
my
those
next question.
with,
Yeah.
yeah, especially in those with major mental disorders co-occurring with substance use disorder. It
Yeah.
may be that our first line should actually be long-acting injectables,
Right.
especially the newer ones that have very little in terms of side effects and can ensure compliance as well.
That was my next question actually. So let's say
Yeah,
we have a patient who comes in with a major or level one psychiatric mental illness, right? Instead of
yeah,
starting him on pills and medication, can we
yeah,
not start him on injectables immediately so we can start
yeah.
working on his other addiction issues as well? Is that possible?
Well, for some of the injectables, we need to actually start with an oral first
I see.
to ensure that they can tolerate it.
Okay.
So, maybe for a few days, for 1 or 2 weeks, they need to be in an oral medication, and then we know that they're tolerating well. Then we start the injectable. So, in some patients, we cannot start immediately, especially with some types of long-acting injectables. But it's still first line. Our
Mm.
goal is that it'll be first line. It's just that in the initiation of it, we have to start with the oral medication for a temporary period.
Mm. To observe any side effects and how the patient is
Yeah,
reacting, I suppose, right?
yeah,
What about
absolutely.
this? What about the new injectable that you just mentioned, Philip? The one that can last to 3 months, long acting. When will
Yeah,
that be out?
yeah.
Is it available in the market already?
No, it's not. It was meant to be launched, but then the MCO started, so no launch can be done during this period. So we'll have to wait for everything to settle before I think we see it being used regularly. Yeah,
Okay. See, that's the benefit of medication because there's always
yeah,
research and reviews and new stuff coming
yeah,
out, right?
yeah,
And there are always opportunities to get better stuff in the market, lah.
yeah.
I
yeah.
I suppose it's important for people to understand that the medications actually play a very important role in recovery and treatment.
Yep. No, absolutely. I mean, this has to be a discussion with the patient and with the family as well. And,
Mm,
they need to be sold the idea that, being on this treatment will be to their benefit.
mm,
And, family also have an important role in that whole process because, you know,
mm,
adherence is not just the single person sort of responsibility. It's the
mm,
responsibility of the people around them as well.
mm,
And so, everyone should understand about the treatment, the medication, and its purpose, and also the holistic approach. What else is, above the medication alone that needs to be, sort
mm,
of continued and complementing the medication and treatment as well. Yeah.
mm. In fact, I have to add this here. Sometimes we see
Mhm.
patients, and we
Yeah.
know medication is important. Of course, it's very
Yeah.
important. But
Yeah.
sometimes we see patients coming to us with a bag load of medications. There's so many things that
Yeah.
they and so someone has prescribed it to them. And
Yeah.
what happens is very
Yeah.
often the
Mm.
doctor or the specialist that the patient sees may not
Yeah.
realize that this person has an underlying
Mm.
substance misuse disorder.
Yeah.
The patient
Yeah.
may not have been honest with the doctor and told him that he has got a
Mm.
substance misuse. So the
Yeah.
doctor may give him medications to treat the symptoms of the psychiatric illness. But
Mm. Mm.
addiction now is overlooked, right?
Yeah.
So the patient goes home with a bag of medication and then has his substance at home to misuse as well.
That's right. Well, I mean, often it's a shot in the dark, right? I mean,
Yeah,
if you're not aware, you don't know how to manage people with a co-occurring disorder,
yeah, yeah.
you're just shooting everything that you
Correct.
can at them, and typically people with co-occurring disorders or dual diagnosis, they don't get better with just that one single dose or medication or,
Yeah.
what you normally expect. And
Mm,
that has to ring, red flags in your brain.
mm,
And so the treating clinician should actually identify, well, maybe this is not as simple as, what I thought. I need to
mm,
get a better assessment done. I
mm,
need to inquire about substance use disorders or physical health problems or
mm,
other underlying problems that are
mm,
complicating this mental health issue that I'm trying to treat.
mm,
And I think that's the important thing that clinicians should have in their minds
mm,
when
mm,
people don't start to give the response that they expect.
mm,
The other thing, of course, is, very often people with substance use disorder, they know medications and treatments very well.
mm.
They can be doctors themselves very often, and
Yes.
so they approach clinicians, and they will have their preference list of medication that they want. On
Mm,
top of that list is Domicum or Midazolam or Xanax or
mm,
Alprazolam. And
yes.
so you need to be suspicious when patients
Mm,
approach you with this. They're coming in with, I have all this ADHD symptoms. I just
mm,
downloaded this questionnaire from
mm,
online, and I'm
yes.
ADHD. Treat me. You know.
Yeah.
So yeah, so I would be a little bit more cautious and want to do a complete assessment and then understand, where they're coming from with these symptoms and what's their real purpose in actually seeking these treatments as well.
Yeah. When you said ADHD, I was smiling to myself because of some of
Mhm.
the patients that we have seen who
Yeah,
abuse the medication and
yeah,
also are abusing drugs. And then he comes with ADHD, and then with those days it was Ritalin, right? And then
yeah,
he takes home the Ritalin, and then suddenly you see white powder under his nose, and he walks out store dry, and then you see the
yeah,
Ritalin missing.
yeah, yeah, yeah,
So
yeah.
I,
So
I I have to agree with you that clinicians. I mean, we need to be more inquisitive and probe and yeah, it's a process, like it's a very long process. In
absolutely.
fact,
I mean, it's both ways as well. I mean, even in a person who presents with just substance use disorder, you
mm,
need to have those inquiries or assessment for an underlying mental health issue as well. you
right,
know so similarly, with a person with a mental health issue presenting to a clinician, they need to also be assessed for a substance use disorder. And I think it should be part of our routine assessment in all patients, because we know substance use is actually on the rise. We know
mm,
that 40 to 60% of people with substance use disorder have an underlying or co-occurring mental health issue. And
Yes.
so we're just going to miss all these people, and we're just going to contribute to the revolving door of
Mm,
relapses and
mm,
disability and all of that it's associated with.
mm. Okay. 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 Wow. Very interesting, and we have overshot the time, Philip. I'm sorry. I told you 30 minutes, and we have shot up to 35, 36 minutes.
That's all
Um,
right. I brought my tea along, so I am.
so did I. So it's good.
Yeah, good.
But this is an ongoing debate for clinicians, and
Yeah,
especially for many of us in the treatment industry, working with people with substance misuse conditions.
yeah,
Um, we get confused sometimes between the mental health illness and the substance misuse. He comes in normal, then when the family comes and admits the patient, he
yeah,
stopped his drugs. He seems to
yeah,
be functioning. After
yeah,
a week, suddenly he becomes psychotic and trying to
yeah,
explain to the families, that the
yeah.
drugs have helped to mask the symptoms.
Mm,
So I
true.
think there's a lot, really definitely a lot for us to understand.
Mm,
It's a multivariate condition
mm,
that requires a very
yeah,
holistic treatment approach. Lah. But I suppose what's helpful now is that
mm,
we work as teams. I think that's been very helpful.
yeah,
Right? Your
absolutely.
presence has been very helpful for our patients. Your input,
Uh-huh.
uh,
Uh,
yeah, it's been very
Thank
helpful
you.
for us. Thank you
Yeah,
very much. Thank you for all your input
yeah,
and
it's
all
all
your
right.
sharing.
Yeah.
You,
Thank you for having me.
Oh, it's a pleasure. It's always a pleasure to chat with you. In fact, you're always around when I need you for a video or for an interview or for a chat. I can just call you.
Yeah.
Thank you very much for being present.
Well,
Um,
like I said, during this period, there's no place to go. So yeah,
okay, I'm just quickly looking at any questions that are coming up,
yeah,
and if we want to take them. There's a question here on etiology, not geology. I don't know. We missed that earlier. I not geology. So maybe we may have missed something. I'm sorry about that. Um, I saw one question which we answered. They want to know about
yeah.
how long after would we know whether the mental health disorder came first or the substance misuse came first.
Mm.
I suppose you answered that earlier. You want
No,
to quickly
again, the
summarize?
important thing is first, do we need to know?
Yeah.
Because they're co-occurring, and I think the important thing is to address and treat both. Uh, Once you've used a substance for more than a year, you have a dependence disorder, and a dependence disorder has neurochemical and gene changes in the brain. So
Mm,
even if you started as self-medicating, meaning you had an anxiety disorder, you self-medicated with a substance, but you used
mm,
it for more than a year and you've been regular with the substance, you have two disorders already. Like
right.
it or not, you have two disorders. You have to treat both, you
Okay.
know. So yeah, I don't know whether there's a real need for the chicken and egg thing, but very often in my practice, it takes time before I really understand which
Mm,
came first. Because I
mm,
need to build that relationship. I need to understand the patient in depth, and I need to have that family interview. And it may take several sessions before I actually can come to a conclusion. Sometimes I don't, you know,
yeah.
but the treatment is still important for both conditions.
Yeah. I have to agree with you because sometimes we don't as well.
Uh,
And it takes a while before you can even gain a therapeutic relationship with the patient to dig all the
yeah,
information out.
that's
Um,
right.
we need to understand that the patient comes from a difficult situation for him to build trust with us.
Yeah,
We need to allow him the space and time. Then there's the family as well. And
yeah,
I also think it may take even up to a year, um,
yeah.
looking at our experience, to
Mm,
actually understand. But
yeah.
maybe it doesn't matter. I agree with you. It doesn't matter.
Mm,
Okay. There's another question about medication as well. There's someone with a mental health condition have to take medication for the rest of their life, which I think you answered. But you want to quickly touch on that, Philip?
yeah, so I don't think there's a rest of your life thing in mental health.
Yeah.
Uh, some people learn new ways of dealing. They make a lifestyle change. The same thing is with addiction. You make a lifestyle change. You have a new set of friends. You cope with stress better. You're problem solving. You got a new goal and purpose in life. Then you can come off even therapy and treatment.
Mm,
The same way with mental illness.
mm,
So if you're on treatment and you learn new ways of dealing with things, you
mm,
can eventually come off treatment.
mm.
But for different people, it takes different time frames. For
Yeah.
people who've had the illness over and over again, it may take years and years. And
Mm,
so, in that period of time, they need that support with the medication to
mm.
help with the process of making their lifestyle change. But
Okay.
in some, it happens very quickly. And so, yeah, I don't think there's a blanket thing that says everyone on treatment for the rest of their lives. It's tailored into the individual, depending on how they present, depending
Mm,
on their prognosis, depending on how they progress as well.
okay. All right. Thank you very much. That's helpful. Okay. I think that's the questions for now. There will be more later. I would probably SMS them to you, or send them to you, Philip, if it's relevant, and then we can
Sure.
post them on the Facebook. Is that okay?
Yeah. Yeah, that's fine. Yeah, I can help out that. Yeah.
Okay. All right. Thank you very much again for joining us.
Thank
Selamat
you.
Hari Raya.
Yeah, Selamat Hari Raya. Yeah, Maaf Zahid dan Batin.
Yeah, Maaf Lahir Batin. And stay safe. And thanks, Philip. We'll speak to you soon. You have a good evening.
Okay.
Thank you.
You too. Good
Bye bye.
evening. Okay. Bye.